Fibrosis is a hallmark of the disease, and it's integrated in the way we understand the disease and how we treat it and how we evaluate success for myelofibrosis. Many of our active agents actually result in clinical benefit and reduction in fibrosis, but there is a new generation of drugs that are targeting fibrosis per se as the way to tackle myelofibrosis. Many of those studies, many of those agents are in early development. So far, we have not had a earth-shattering or breaking data that will change our practice anytime soon, but there is a momentum towards that direction, and hopefully we can advance that in terms of combinations. The currently approved agents for myelofibrosis, as well as agents in late-phase clinical trial design, are showing activity in modifying fibrosis and the microenvironment of myelofibrosis. And the more active agents and combination we have, we're seeing more deep and more impactful change in the bone marrow histology. We believe that fibrosis is essential in the pathogenesis of the disease and the niche of and the microenvironment of the bone marrow, and how patients clinically eventually improve with that. However, we haven't yet gotten it right to understand how can we use measurements of fibrosis as an endpoint in designing clinical trials, and how can we incorporate that in our success or lack of success measurement of new disease. Of course, the response in fibrosis is drug dependent and agent dependent, and it's impossible to extrapolate the data from each drug into the data of other active agents. This issue continues to evolve, and it's an exciting story, and hopefully we'll have agents that tackle myelofibrosis and normalize the morphology of the bone marrow, including change in fibrosis.